What's the medical consensus for age of viability of a fetus?
I appreciate the question. So viability is a complicated medical construct. There is no particular gestational age. There are some pregnancies in which a fetus will never be viable. There are a number of different factors that we think about when we're considering if a pregnancy is or isn't viable.
So is there a legal consensus on the age of viability?
Not to my understanding, but I'm a physician, not a lawyer.
What's in your 10 years as a doctor, how many abortions have you performed?
So I provide a variety of different services, and
I'm not asking about the other services. How many
Right.
abortions have you performed?
So I can't tell you how many hysterectomies I've done, and I can't tell you how many abortions I've done. I've had a long career of taking care of people for a variety of things.
So you manage a facility. Can you tell me, or you're the medical overseer of that, can you tell me how many abortions the facility in Missouri performs each week?
I can tell you, and I believe it's publicly available, so I can give you a rough estimate of how many abortions we perform per year, which is, I think, roughly around 3,000.
How do you dispose of 3,000 fetuses every year?
So Missouri has a state law that requires that we send all of the remains of pregnancy to pathology.
What's the latest term abortion that you've performed, like gestation period in weeks?
So my practice includes the provision of abortion up until the point of viability. And again, we already had a discussion about viability not being a...
So just give me the number in weeks then.
I don't know.
You don't remember the number of weeks?
That's correct. So
what about size of the unborn baby? Do you know the largest baby that you've aborted?
I'm not sure how I would even quantify that.
If I use the word fetus, do you know, you have no idea the age or gestation period of the fetuses that you're aborting?
So again, as I said, my practice includes abortion care through the point of viability, and as we previously discussed, that could be
let me put it this way.
Point, yes.
Is there any point of gestation beyond which you personally would not abort a fetus?
You know, medicine is not black and white. I recognize, in my 10 years of practice, informs this opinion that pregnancy can be really complicated, and given that there are pregnancies for which a fetus may never be viable, I think it's really important that we allow physicians and patients to have every medical resource to make decisions that are appropriate for them and their health.
In the absence of a law preventing it, would you abort a viable fetus?
Again, every patient is different, and I can't make any...
I'm just asking about a viable fetus. If the law didn't prevent it, would you consider it a limitation morally for you to abort a viable fetus?
So I think you're forgetting that there are a number of reasons that go into patient's choice.
I thought you, at your clinic, does it matter what the reason is for the abortion?
At my clinic, I trust that women have a valid reason. Every reason that they have is valid.
Okay, so given that you think that every reason is valid, would you abort a viable fetus if there was not a law preventing it?
Again, given that the reality for people choosing abortion is that there are many reasons, there isn't a single thing that defines somebody's choice. It is a reflection of their...
You seem to have a hard time saying this. This tells me you have a heart, or at least you know that people watching this have a heart, and they would be concerned if you would just admit, which you won't admit here, that you would abort a viable fetus for any reason if the law did not prevent it.
Mr. Massey, abortion is moral, it is important, it is health care, and I support people being the experts in their own lives and making decisions for themselves.
It gives me some hope that you here understand that people do not support you when you say, or if you would say that you would abort a viable fetus for any reason. But given what you told us in your opening statement and knowing what you've said, we know that you would. But it does give me hope that you still know in your heart that's wrong. Mrs. Stuckey,
I'm not sure. Can I respond to that really quickly?
If you would answer my question, you could, but you won't. So I'm going to use my remaining time asking Mrs. Stuckey, should any reason be a good reason for having an abortion,
Absolutely not. It's a child. It's a life inside the womb from the moment of conception onward. And I'm very troubled by how flippantly she said that there are 3,000 abortions performed every year of defenseless human beings, and the remark that abortion is moral.
Time has
I
expired.
can
I
imagine
reckon
that
the
kind of
we had-
logic
we
driving
had-
my lifestyle.
No, the time has expired. I recognize.
Gave the others
woman.
over 2 minutes over, Mr. Chairman. Mr. Chairman, we need to be fair on both sides of the aisle, please, sir.
You want to finish your.
Please, I'd like for.
No, finish your answer. Go ahead.
I don't quite understand the logic of saying that killing a child inside the womb for any reason whatsoever is moral, is healthcare. In what other situation, besides when a child is defenseless in the womb, do we call killing someone healthcare? Do we call killing someone moral? Can anyone on the pro-abortion side tell me a situation outside of a defenseless child inside the womb in which it is morally justifiable to kill someone simply because they're not wanted? That's the answer, or that's the answer that I would like. That's the question that I have. I unfortunately don't think anyone's able to answer it for me, which is exactly why we've had such a hard time getting any kind of clear answer from any of the panelists of what abortion actually is. What does it do? Because talking about tearing a child apart limb by limb with forceps just isn't a very good PR strategy for Planned Parenthood or the abortion industry. All I'm trying to do is to remind us when we're having this conversation that there are two people. There are two people.
Recognize for 5 minutes.
Thank you, Mr. Chairman. Seems to me that a lot of this debate and argument centers around whether or not the baby is a person or a fetus, and I recognize that many on the other side of the aisle refuse to recognize the baby as a baby, refuse to recognize it's a person, it's humanity. Ms. Stuckey, there have been a lot of medical advances, certainly over the last several decades. Can you tell us about some specific scientific evidence supporting the personhood, the humanity of the baby, and the viability?
Well, embryology tells us, thank you for your question. First of all, embryology tells us that the child from the moment of conception has a separate DNA. And so when we hear these euphemisms thrown around, like my body, my choice, immediately obscuring the life of the child, it shows me that the pro-abortion argument doesn't deal with fact, it deals with feeling, which is exactly why we've had such a hard time getting any kind of clear answer from any of the panelists of what abortion actually is. What does it do? Because talking about tearing a child apart limb by limb with forceps just isn't a very good PR strategy for Planned Parenthood or the abortion industry. All I'm trying to do is to remind us when we're having this conversation that there are two people. There are two people. And I don't believe that we have to pit a mother against her child in order for a woman to be successful. We talked about, legislative solutions and showing compassion for children after they're born. I absolutely believe in that. Every pro-life pregnancy center that I've ever been a part of, that I've ever donated to, they don't just counsel women. They also offering parenting classes. They are also offering help from abusive situations. They are offering programs for these young women to be able to get affordable baby clothes and baby products and things like that. And so every pro-life organization I know cares about children in the womb after they're born and the mother who is pregnant with these children. That is what I am trying to argue, that let's not ignore the scientific reality that a baby is a baby and therefore, in my opinion, is deserving of the right to life.
There's not a person I know that say they're pro-abortion, they're pro-choice. So abortions are not infanticide. That is not how abortion works. And this type of deceptive rhetoric is yet another attempt to distract from efforts to make abortion out of the reach for women to shut down clinics. And I just constantly, I've had this debate a number of times on this panel. The mistruths that are spoken about ripping full-size babies out of wombs and killing them, that is not true. Selling of parts is not true.
Hello, I'm Cecile Richards, President of Planned Parenthood Federation of America. I want to be really clear. The allegation that Planned Parenthood profits in any way from tissue donation is not true.
What would you expect for intact tissue? What sort of compensation? What sort of...
Well, why don't you start by telling me what you're used to paying?
We'll be exhibiting at the Medical Directors Council
good.
meeting
Good.
in a couple of weeks, so I don't know if you'll be attending.
I'm now the president of that organization.
Oh.
So we had just started the conversation, and Susan was a clinic. They're a startup that they have been about a year in business. They're a for-profit company that's connecting researchers with people willing to donate tissue. Our volume, thank you for giving it to me, is 800 a year with 60 in the second trimester. And we just started to talk about how the process worked with Novogenics down in Los Angeles when I was there.
Okay.
To back up a little bit, PPFA, our parent body, is on board with tissue donation, but we have to ask for a waiver to do it, and we have to lay out for them what our program's going to be like. And the mechanics of it was that Heather, Novogenics person, would come to the site, and our staff would sign the patients up and get consent, and then Heather would look at the tissue and take what she required. So it was logistically very easy for us. We didn't have to do anything. So there was compensation for this. We didn't have to do anything. So there was compensation for this, and there was a discussion as I was leaving. They had been paying by the case, and there was some discussion about doing it in a different way, or I don't know what you're used to doing, how are you used to doing compensation. The patients don't get anything, of course. But.
Okay, so I'd like, what would you expect for intact tissue? What sort of compensation? What sort of...
Well, why don't you start by telling me what you're used to paying?
Okay. I don't think so. I would like to know what would make you happy. What would work for you?
Well, you know, in negotiations, the person who throws out the figure first is at a loss, right? So.
No, I don't look at it that way. I know you want to play that game. I get it, but no, I want
lowball because I'm used to low things from.
You know what? If you lowball, I'll act pleasantly surprised, and you'll know it's a lowball.
Okay.
What I want to know is what would work for you. Don't lowball it.
Okay.
Tell me what you
really. $75 a specimen.
Oh, that's way too low. And that's really way too low. I want to keep you happy.
I've been at places that did 50 too. But see, we're not in it for the money. Well, why don't you start by telling me what you're used to paying?
Oh, no, I want
lowball $75 a specimen, and we don't want to be in the position of being accused of selling tissue and stuff like that. On the other hand, there are costs associated with the use of our space and all that kind of stuff. So what would you think about?
Right. So way higher than that. So I'd like to start at around 100.
Okay. Now this is for tissue that you actually take, not just the tissue that the person volunteered that you can't find anything. Right?
Exactly.
Now this is for tissue that you actually take, not just the tissue that the person volunteered that you can't find anything. Right?
Exactly. Right. What we can use, what is intact. So that's why I'm saying no, don't lowball. I want you to be happy.
It's complicated by the fact that our volume is so low too. I mean, are you looking at 8 and 9 week specimens or only second trimester specimens?
10 to 12 week, end of the first trimester. If those are pretty intact specimens, then that's something we can work with.
So that's an interesting concept. Let me explain to you a little bit of a problem, which may not be a big problem. If our usual technique is suction at 10 to 12 weeks, and we switch to using an iPass or something with less suction in order to increase the odds that will come out as an intact specimen, then we're kind of violating the protocol that says to the patient, we're not doing anything different in our care of you. And to me, that's a kind of a specious little argument, and I wouldn't object to asking Ian, who's our surgeon that does the cases, to use an iPass at that gestational age in order to increase the odds that he was going to get an intact specimen. But I do need to throw it out there as a concern because the patient is signing something and we're signing something saying we're not changing anything in the way we're managing you just because you agreed to give tissue. I've heard of that before.
Right. Yeah. No. It's definitely.
It's touchy. Okay. How do you feel about that?
Well, I think they're both totally appropriate techniques. There's no additional pain involved. I don't think the patients would care one iota. So I'm not making a fuss about that.
Okay.
Now you have my email address, right?
Got your email, yeah.
Okay. Write me a 3 or 4 paragraph proposal, which I will then take to Laurel and others in our organization to see if we want to pursue this. And then if we want to pursue this mutually, I'll mention this to Ian in terms of how he feels about using a less crunchy technique to get more whole specimens. And then if we agree to move forward, the next steps I need to apply to PPFA for a waiver to permit us to do this. We have to have a contract. Do you have a contract already?
We have what we've used in the past is a materials transfer agreement. And that's obviously open to discussion.
So that's a prototype. It needs to say exactly what your staff is going to do, exactly what your expectations are, exactly what the compensation is.
And are we agreed that $100 would keep you happy?
Well, let me agree to find out from other affiliates in California what they're getting. And if they're getting substantially more, then we can discuss it again.
Yes.
But the money is not the important thing.
No,
but it has to be big enough that it's
But
worthwhile
it
to
is something to talk about. I mean, it's one of the first things that you brought up, right? So,
it has to be big enough that it's worthwhile
but it is something to talk about. I mean, it's one of the first things that you brought up, right? So.
Now here's another thought: is we can talk about specimen as per specimen per case, or per procured tissue sample, which would be so that if we're able to get a liver thymus pair, maybe that is $75 per specimen, and so that's for for liver thymus pair, and that's $150, versus if we can get liver, thymus, brain hemisphere, and all that, then and then so that protects us so that we're not paying for what we can't use. I think it also maybe illustrates things.
It's been years since I talked about compensation, so let me just figure out what others are getting, and if this is in the ballpark, and that's fine. If it's still low, then we can talk about it. I want a Lamborghini. I said I want a Lamborghini.
Don't we all, right?
Yeah, exactly.
This Philadelphia doctor, who gave abortions to minorities, immigrants, and poor women, has been charged with 8 counts of murder. It's in connection with the deaths of a patient and 7 babies who were born alive and then killed.
They learned that in case after case, Dr. Gosnell and his assistants induced labor, forced the live birth of viable babies in the 6th, 7th, and 8th month of pregnancy, and then killed those babies by cutting into the back of their necks with scissors and severing their spinal cords.
Prosecutors said the 69-year-old doctor performed as many illegal late-term abortions as he could. Gosnell allegedly made millions of dollars over 30 years. Philadelphia's district attorney said state regulators ignored complaints about him and failed to inspect his clinic since 1993. Early last year, authorities went to investigate drug-related complaints at the clinic, and then stumbled on what the DA described as a house of horrors.
Bags and bottles holding aborted fetuses were scattered throughout the building. A row of jars containing severed feet lined a shelf.
The clinic was shut down and Gosnell's medical license was suspended after the raid.
Is strongly advised.
I was an OR assistant. I did a lot of parts of the clinic, and one of my jobs was his right chair assistant. And I never paid attention. I did pay attention, but I didn't know that it was illegal. When he did an abortion, especially a over 20-week abortion, most of the time the fetus would come completely out before he either cut the spinal cord or he introduced one of the instruments into the soft spot of the fetus in order to kill the fetus. But I wasn't aware. I thought, well, it's an abortion. That's what he does. But I wasn't aware that it was illegal. And on many occasions we had fetus that he would use the process as far as what is it called, where he would dilate the cervix and then dilate the cervix, evacuate the uterus, and most of the time we would see him where the fetus would come completely out, and of course the fetus would still be alive because it was still moving, and you could see the stomach breathing, and that's when he would do his he would snip the spine, as they're saying that this doctor did, and of course the soft spot was one of the spots that he would take one of the forceps, or the, what is it called, the dilators, and stick it down the soft spot of the fetus's head.
You saw this happen?
Oh yes, I think every morning I saw on several occasions. If we had 20-something patients, of course, maybe 10 or 12 or 13 or 15 patients would be large procedures, and out of those large procedures, I'm pretty sure I was seeing at least 3 to 4 fetus that were completely delivered in some way or another, because sometimes laminaria causes the cervix to get so soft that you don't need a lot of pulling or anything on it. Once you take that package out, 9 times out of 10, that fetus is ready kind of just to flow from inside of the uterus out into,
When you say package, you mean the laminaria?
The laminaria package insertion, yes,
Right.
sir.
You take that out and the baby's ready to come out?
Yes, sir. As soon as that, or sometimes he would go ahead and bust the water sac, and there you go. You practically had a fetus, in the pan. So.
And you see the baby alive?
Yes, sir.
And him kill that baby outside the womb?
Yes, sir.
And this would be done by jamming some sort of instrument into the
either that or
soft spot,
or twisting the head off the neck, kind of with his own bare hands.
And you saw that happen?
Yes, sir.
Mm-hmm.
So he would twist the head off. I'm sorry.
Sometimes he would go through the stomach as well.
Sometimes he would do what?
He would force it through the stomach.
The instrument, is it beards?
And twist it.
Yeah.
And you saw that?
Mm-hmm.
Anything that he could get to the fastest, like she said, the umbilical. He was probably perforating the umbilical cord. I normally saw either the snipping of the spine or the introduction of the instrument in the soft spot of the fetus, normally, or twisting of the neck.
I remember he would put his finger.
Yeah, or his finger. He'd take his finger and then
through the throat.
Yeah. You remember that the one that he did with the baby, the fetus came out and it was alive. He thought he had actually killed it already, and he opened up his eyes and grabbed his hand, his finger. Remember that one?
No. What happened?
Supposedly they said that it was a botch, and it was a botched abortion. The fetus was still alive. He thought it was dead, and the fetus opened his eyes and actually
grabbed his finger.
Was able to grab his finger. And the whole procedure, I guess, while he's doing the procedure,
he was getting.
Because after the fetus, of course, he has to massage the abdomen to bring the placenta down, or grab it with the forceps to bring it out.
And this baby was
alive.
Now, huh?
He was alive.
Well, yeah, if he's looking at him grabbing his finger.
Yeah. He thought he had finished with the baby.
He thought it was deceased already.
It was a disease already. He was getting ready to put it in the bag.
Did he talk about that?
One of his employees did. That's how I found out.
He doesn't talk about that. He doesn't make any comments about it.
How did he kill that baby? Do you know?
We found out about it through another employee. I don't think that was said how he killed it. I'm not sure. It must have been a big abortion, though, I believe. Can't really recall, but I know that he does a lot of huge abortions. A lot of the times we would bring the big fetus that were over age, and we would reopen the bag and just look at it and be like, oh my God, it's so big. We would be amazed how big it was, and we'd be sweating and stuff, because it'd take us almost an hour to perform an abortion that big. It's really hard when you only get doing an abortion that big and only dilating with maybe 13 to 14 laminarias in the cervix. It's kind of hard. Sometimes he couldn't get the fetus out. He would yank pieces, piece by piece, when they were over the size. And I'm talking about the whole floor dirty. I'm talking about me drenched in blood. We had several occasions that where women would come in and they would actually be going in labor because that overnight insertion, the package, he might have gone a little bit too far, would put in too many in there, and some women had started to cramp, and sometimes they would get to the clinic and they would make it to the OR room because they're in a line, and you know, when they get there, they give them these pills called Cytotec, and they put them in your gums. And it takes, I'm thinking it takes about an hour before you get a full effect, and that makes your uterus start contracting. And so a lot of, we've seen a lot of cases where women would have to, they felt like they had to push and they had to run to the bathroom and stuff. And on some occasions we had women that were, the fetus were falling into the toilet, or they were, or before even getting to the clinic. We had one incident where it was big news, where the fetus was left in the toilet. I don't know if y'all heard of that one. She was at McDonald's. They stopped there in the morning and the fetus was left in the toilet, and nobody ever found out whose fetus it was, but it was one of his patients. We knew it because we were watching it on the news that day that she was supposed to be in the clinic.
Do you remember that one that she was on her way to the OR, Crystal? And she was walking to her OR and she had it right there in the hallway.
She had her baby in the hallway?
Yes.
And what happened to that baby?
I wasn't down there when that happened. Were you down there?
He just picked it up with like a pad, one of those
chucks.
A chuck.
Uh-huh.
And just put it in a trash bag.
On some occasions, of course, he pulled out a lot of breech fetus, and their toes would be moving. You know, you can see the fetus toes moving. And as he would insert the forceps, what are they called? The beards. There's two types. There's the beards, and then there's the sophers. The beards are the ones with the bigger claws, and that's the one he would use to yank the fetus out. And I remember, I have a visual all the time. I always remember this. It's real disturbing to me, where he used to clamp, like push it in. He would hold the fetus by the feet and kind of pull down and insert the claws. And when he would squeeze them, you can see that baby's toes spread open. And I would always say, oh my goodness, you know, and people say that that they don't feel. Well, if they didn't feel, why would their toes, you know, their toes would be out hanging kind of like in a, what's going on, you know, where am I going? And I remember clearly every time he used to use that instrument, I remember those little toes, you know, opening wide. It was a sad picture. I normally would turn around, kind of just hold and, you know, just turn around until he was finished. And he would do abortions way over 24 weeks. I mean, there's a big difference in a 24-week fetus, and every week from 24 on up, that 1 week is such a big difference. I'm talking about big fetus. I'm talking about being in the OR about an hour trying to do one procedure that big. I'm talking about being really tired after this procedure from where he could not get this fetus out, you know, and it's very overwhelming. We used to look at each other, and sometimes our tears would come out, you know, with the other assistants. Our tears would come out because we would say to ourselves, why? We would always think he's so greedy, you know, and we were not talking about normal price. I'm talking about $4,000, $5,000 for a procedure this big.
As long as the patients had the cash, he was going to do it past the 25 weeks.
Yeah.
Did you ever assist like?
Yes, I did.
You did? Mm-hmm. What kind of experiences did you have?
The same thing she did is the same thing I did. I would tell Deborah all the time, Deborah, I don't want to go in there. I don't want to go in there. And he would tell me, like, you can do it. You can do it. If you feel like you just can't look at it, just turn your face.
He wanted me in the phone room because I've always been pretty good at appointments and, you know, talking to people and convincing them to come to the clinic. I just knew my way, you know, as far as talking to patients, being real good convincing patients to make appointments. And so that's when he threw her in the back office, which was OR, sterilization, you know, things like that. I mean, there's a lot of things. I mean, from these large abortions, these botched abortions that he was doing, to hurting the patients on the table, to causing some kind of major problem with the woman's, ripping a uterus and not letting the patients know, trying to stitch them back together and send them home with the package of gauze, and then they come back tomorrow so you can pull it out, but never telling the woman, hey, I ripped your cervix. You need to get some kind of special, you need to get that looked at, he would never tell the woman.
And if he had a patient that asks a lot of questions, he'll prefer for them to be put to sleep.
Yeah.
Oh, really?
Yes.
Any little comment that you would make as far as if you were on the table? It was his way of making more money, of course, because deep sedation meant dishing out another $200. So if you made, is it going to hurt? I mean, this man would walk out the room and say, Deborah, go talk to her, tell her she needs to get put to sleep. And normally it was our job to go convince the girl that she had to get put to sleep. And a lot of them would raise a lot of hell.
Right.
But they didn't have no choice. They had to do what he said, because guess what? You're going to lose $150. In other words, that was $150 that you did not get back. So a lot of them would either lose the $150 or pay the $200 and go ahead and get it over with.
So other employees besides just Deborah and Crystal knew that these sort of things were going on?
Oh, yeah. Everybody there.
Everybody knows. It's an open book.
Yeah. The women that go there have no idea what they're getting themselves into. A lot of the questions have been, does the baby feel? And I think that would make me so mad, because I would say, why would that matter to you if you're coming in here to kill your baby? Why ask that question? And of course you would want to say, yeah, it feels, but that wasn't your job to say that. Your job was to, whatever it took to get that person in the back,
La